Greetings to you all, and thank you for joining us today. Um, it's a very exciting session that we're going to have. Just to start, my name is Benjamin Kagina, and I'm the director of Niche All Nighter Support Hub. And part of the niche work is hosting webinars, particularly with topical areas of interest to NITAGs. And in today's webinar, our focus is on preparing for new TB vaccine introduction. I think for those of you who may be joining us, having joined the previous webinar, which we also introduced the context of modeling for TB vaccine introduction, this is a continuation to that. And today's program is very well structured with some exposure to WHO guidance on using modeling for immunization decision making, and then hear more about Malaysia experience and also Kenyan's experience. Um, and also crucially, we're going to hear from Charles on vaccine confidence in adolescents and young adults who are likely to be the target group for new TB vaccines. So, just a few admin or operational things. We do have interpretation services. So if you go to your Zoom window on the bottom right, you'll see more. And if you click on that, you will be prompted to click a globe with interpretation services. And if you go there, you're going to be able to select your preferred language, whether it's English, French, or Portuguese. And now, just to mention that Niche is funded by Wellcome Trust to work with Gambia NITAG and Kenya NITAG and South Africa NITAG. So those who attended the last webinar on modeling for TB vaccine, South Africa NITAG shared their experience, and today we're looking forward to hear the experience of Kenya NITAGs. So, with those few welcome remarks, it is wonderful to have you join us on this webinar session. And I will now hand over to Sheetal, who is going to introduce our next speaker. Sheetal, over to you, and thank you very much.
Thanks so much, Chair. And it gives me great pleasure today to start off the first component of our webinar. I would like to introduce our first speaker today, who is So Yoon Sim, who is a technical officer at the World Health Organization. And Uni, as we affectionately know her, has significant expertise in health economics and epidemiological and economic modeling, as well as value assessment and investment case development for vaccines, and with a strong focus on translating evidence into policy through NITAG and HTA processes. So our first talk today from Uni will be on a recently launched guidance from the WHO. So Uni, over to you. Thank you.
Yeah, thank you, Shital, for this introduction. And hello, everyone. Today, I'd like to talk about WHO guidance on using modeling for immunization decision making. And at the end, we'll also like to touch upon some of the application for TB vaccine introduction in Africa. Next slide, please. Yes, I'd like to introduce the rationale and process for WHO guidance, and then move on to deep dive on the guidance for using modeling for immunization decision making, and then questions and answers after Dr. Wan's presentation at the end. Next slide. Next slide. So here we like to focus on mathematical modeling. There are lots of different type of modeling, statistical modeling, mathematical modeling, but here we focus on these mathematical models as all tools that simplify real-world systems. So it is a set of equations translated into the computer codes, usually using software programs, as you see on the right. And then it could synthesize available evidence and information, simulate how disease spread dynamically, and it informs how we can estimate the impact of interventions such as vaccination programs. Next slide, please. We have seen a bit of a disconnects at multiple levels. First, to start with the global level versus country level. As you may well aware, the SAGE, the Strategic Advisory Group group of experts on immunization, this modeling is well embedded in the evidence to decision process according to their method guidance. And there are established protocols of how to use modeling, and then strong access to academic institutions and consortia around the world. However, at the country level, across all income groups, there are different contexts, resources, and approaches with variable use of modeling, with limited capacity, time, and guidance. So first, we like to bridge this gap through WHO guidance. Next slide. And another disconnect is actually the modeling outputs to needs of the end users, the decision makers. So modeling is very helpful to estimate the long-term population impact and compare immunization strategies, especially to explore uncertainty and the scenario planning. It will also be used for cost-effectiveness analysis. However, there's a need to actually judge more critically this modeling evidence for decisions to local context. You need to understand assumptions and limits and assess uncertainty and credibility, and also consider this alongside the other type of the evidence. So WHO guidance basically provide tools, questions, and processes to do this more systematically. Next slide. So guidance development actually took place over 2 years. Was an initiative led by WHO, informed by very critical advice from WHO's Immunization and Vaccine Related Implementation Research Advisory Committee, chaired by Professor Shital Silal, who is here today. Our target group is stakeholders involved in decision-making processes, including NITEC members, RITEC members, ATI managers, technical working groups, and partners the event to ultimately to position modeling as an input among other sources of evidence, such as trials, observational studies, and market information, among others. Next slide. So it was composed of the 3 stages. So from the outset, we placed the needs of the end users at the center of the process, and then the findings from the needs assessment informed the both format and content of the guidance that we are presenting today. And looking ahead, the next step will focus on translating this into training and practical support for country stakeholders. Next slide. So the needs assessment, let's start with the needs assessment. And then we try to look at and understand how modeling is currently used, identify end user needs and challenges, and define the most useful guidance format. So several important findings emerge, as you see on the slide on the right. So the use of the modeling varied considerably across countries. Local context matters. Many stakeholders highlighted the need to strengthen translation capacity, the ability to assess, validate, interpret, communicate modeling results for policy use. And also, the needs assessment reinforced the importance of the co-creation based on trust and routine engagement. Finally, we heard very clearly that it should not simply sit on the shelf. The guidance should be accompanied by interactive training, practical tools, and a community of the practice. Next slide. And this is the document itself that you can actually quickly access with this QR code. And then it is a collaborative effort across many stakeholders who provided input into this guidance. And also, we like to highlight that this accompanying commentary has been published to emphasize also the strengthening the translation capacity is only one element of enhancing the model use in a broader ecosystem. Importantly, this work sits alongside many other initiatives led by global partners around the world, including NITEC Support Hub's own efforts to address structural inequities in the production and use of modeling. Next slide. So next step, we are looking forward to deepening further and tailoring further this guidance document into online course training and ongoing support, training modules and community of practice, all in partnership with the local institutions around the world across 6 WHO regions. And then, as you also see on the left, it is a NITEC resource .org, NITEC Resource Center training page, where you'll periodically check and find out the updated materials hosted there. Next slide. And let me just speed up to jump into the content of the guidance and present some of the key tools from the document. Next slide, please. So first tool aims to help determine whether modeling could provide useful information for your decisions. And it is one of many sources of information and may not always be necessary or appropriate. And here we show when it is particularly helpful, when overall population impact is not captured in available studies, and it could expected only several decades in the future, like HPV or Hep B, or there is uncertainty about virus evolution or vaccine characteristics, which we saw in the COVID-19 pandemic, and or you want to explore multiple hypothetical scenarios or counterfactual that cannot be evaluated as the new TB vaccines, or incomplete or insufficient surveillance data. Next slide. And the second tool shows how to put modeling in the evidence decision process. And then you see this fourth step you may already familiar with, formulating the policy question, define criteria, collect, synthesize, and access evidence for each criterion, and develop recommendations. And most of the modeling process actually fits in the third step of the evidence collation and the review, and we'll jump right into it in the guidance document and how to walk through the steps. Next slide, please. And digging deeper into the modeling process, this composed of the 4-phase problem formulation, data conceptualization, model development, fitting and validation, scenario formulation and result and interpretation. And then the guidance shows what happens at each phase with detailed step-by-step description for what you should do to co-create model from scratch with modelers. Next step. Next slide. And then the technical appendix go further by mapping the task of the decision makers alongside the role and other who may be involved in the modeling process. And especially there's a practical tips for how to collaborate effectively with modelers, how to establish clear roles and responsibilities, best practice for internal communication, and how to ensure respectful engagement, and what useful tools are out there to facilitate such collaboration. Next slide, please. And final tool, what I want to highlight is the checklist of the critical questions to appraise and evaluate the modeling result. And as you know, the unlike trials or studies, observational studies or systematic reviews, model estimates do not usually have a widely standardized appraisal framework. So there's no single correct model for every policy questions. All models have limitations. So it is absolutely critical for you to ask questions that make assumptions, uncertainty, and relevance of the modeling results more explicit. So these are the checklist that I listed here. You can find more detailed in the document. Next slide, please. And another key feature of the guidance is that it uses a hypothetical case example of how a NITEC might use modeling to inform HPV vaccination recommendation. Next slide. So starting with the policy questions formulated into modeling questions, and how you conduct review available local data, identify gaps, assess data quality, and next step will be build a model or use existing modeling results, and then formulating scenarios, interpreting results, and integration into recommendation, all the way to also evaluation of the modeling and translation process. And you'll find the more detailed examples of that built around the HPV example. Next slide, please. And I have 3 more minutes, so I'll just touch upon like how this applies to preparing for TB vaccine introduction in Africa. So I like to, especially with the 9 candidates in active trials as of early this year. Next slide, please. So I'd like to talk more about discuss more at the global level first, and then the country level. So at the global level, in January 2023, the WHO's Director General announced the plans to establish a TB Vaccine Accelerator Council to facilitate the development, testing, authorization, and use of new TB vaccines, especially drawing on lessons we learned from the COVID-19 pandemic and COVID-19 Accelerator. So WHO TB Vaccine Accelerator Secretariat has these 3 different working groups focusing on clinical and policy technical advisory group, and country readiness working group, and finally the finance and access working group. And these are all integrated with each other, and then partners and networks to increase and enable the equitable and sustainable access to the new TB vaccines by tackling the issues across the vaccine value chain. Next slide, please. And especially the Finance and Access Working Group, which is co-led by WHO, Gavi, and the government of South Africa. Recently, they published a report listed on the left that was launched at a high-level event at G20 Health Ministers meeting in South Africa. And then the report highlights 6 urgently needed solutions and priority actions for governments, health partners and funders, suppliers, and civil society to accelerate the TB vaccine access. And one of such solutions is the systematic and early generation of the country-led evidence packages. Next slide. So I'm currently coordinating this task force too, focusing on the specific solution where we aim to develop global cost effectiveness analysis based on mathematical modeling, budget impact analyses, and the cost of production benchmarking that enable countries and donors to inform vaccine demand and financing, and then conduct scenario planning in the absence of complete data. And this is to inform early signals at the global and more aggregate level. And now I'm going to the national level, which is national level decision making and budget allocation occurs at a later stage with the final trial data and product licensure. Next slide, please. Just to highlight also the niche webinar on mathematical modeling for new TB vaccine decision making in Africa. So there are lots of active ongoing work taking place in South Africa and in other countries to put modeling into the practice, the evidence of decision process for TB vaccine introduction. And then especially this slide, all credit goes to Dr. Wasila Jasad from the NAGI TB vaccine working group chair, who outlined how modeling could support NITEC recommendations in each of evidence to decision domain. And also Professor Shital Silal also presented issues to consider when using modeling for immunization decisions. So I highly recommend that you check out the previous webinar to understand some of the country examples of how this operational planning and local coordination takes place at the country level, and how also this could be aided by the WHO guidance that I just presented. And then in the interest of the time, I'll just conclude with the next slide, conclusion slide. And then just to show you that, yeah, mathematical models can be very helpful tool to simulate how and estimate the impact of the interventions. However, it is very important to ask critical questions then to make assumptions, uncertainty, and relevance of the modeling results explicit, and co-creation between local decision makers and local modelers based on your own local data is key to contextually relevant modeling results. And the key tools from this WHO guidance could be applied to TB vaccine introduction in Africa. Thank you very much.
Thanks so much, Uni, for such an insightful presentation. And in particular, I appreciate the way you highlighted that the value of modeling is not just in the models themselves, but in how the modeling exercises are conducted in order to be most relevant for the different contexts in which we would like to apply these interventions, and particularly in our case, TB vaccines. So I'd like to move on to the second presentation for our webinar today, and it gives me great pleasure to introduce Dr. Wan Abdul Hanan. Wan is a public health physician and senior principal assistant director at the Vaccines Preventable Disease Sector and the Disease Control Division in the Ministry of Health in Malaysia. And he has extensive experience in vaccine policy, procurement, program coordination, and is leading currently the National Pneumococcal Conjugate Vaccine Program, as well as being the point person for the polio program as well. So we have great pleasure today in welcoming Wan to continue this discussion along the themes of modeling and doing a deep dive. So thank you, Wan. Over to you.
Thank you very much, Sheetal, for the kind introduction. Thank you very much, everyone. Thank you so much for having me for today. I'll share my slide now. All right. Can you see my slide?
Yes, thanks.
All right, cool. All right. Thank you very much for having me for today's experience. So this is rather going a bit 15 years ago on how Malaysia's experience in the childhood pneumococcal vaccination program. I'm also the lead, I'm a public health physician by training, and I'm the lead secretariat for NITAC Malaysia. It's called NIPPC, the National Immunization Policy and Practice Committee in Malaysia. So basically on my top of my left is the flag of Malaysia. This is the map of how Malaysia's map in the Western Pacific region. I'm also the regional representation in the Global NITAC Network Steering Committee. All right, just how do we do modeling in terms of introductions of pneumococcal disease in Malaysia? So pneumococcal is not a notifiable disease in Malaysia. However, going 15 years ago, there have been the burden of pneumococcal disease is apparent, especially among the clinicians. So, but this is not a notifiable disease, so we do not know the burden, the actual burden, and how do we want to get introductions of the vaccine. And we know that 7-valent pneumococcal conjugate vaccine was licensed back in 2000, and it's available in 2005 in Malaysia. So basically, pneumococcal disease divided into two arms, whether it's non-invasive or invasive, and we have over 100, or to be exact now, if I'm not mistaken, is 107 different serotype. But what is the most of interest is the serotype that could cause invasive pneumococcal disease that breach the normally sterile body compartment. So when you get invasive pneumococcal disease, the children are at higher risk of mortality and morbidity. So it can lead to your blood and cause septicemia. CSF can cause meningitis. So these are the important disease that we want to prevent from pneumococcal Streptococcus pneumoniae. So what we want to prevent is IPD, and according to the clinicians who have seen the patients in hospitals, so the number of cases is there, but it is not in the NIP, although it was licensed in 2005, but it was only introduced in the National Immunization Program in 2020. So it took 15 years. But before that, just this to give an overview of Malaysia's national immunization program. We started in 1956 with diphtheria, tetanus, and later on, 2 years after that, we give tetanus, DPT, pertussis and tetanus. And then over the years, we've introduced measles and a second dose of measles in 2004. And then in 2020, we start giving hexavalent vaccine as well as pneumococcal disease. And just to tap a little bit on this, Malaysia's we've experienced the circulating vaccine-derived poliovirus back in 2019 and 2020 when we have importation CVD-PV1. And then what happened following that outbreak, we've managed to interrupt the transmission, still maintaining the full polio-free status in the region in Malaysia as well as in the region. But following that, Malaysia is currently giving free hexavalent vaccination. It's actually free polio-containing vaccine, but polio-containing vaccine only available in the form of hexavalent in Malaysia. In that sense, it's free for all because of our porous border. So these are the things that the country is doing, to really not just safeguarding the country, but the regions as well, making sure that children, whether it's citizens or non-citizens, are eligible to get vaccination. Pneumococcal disease was introduced, so this is our national immunization, childhood national immunization program in PCV. So going through that, we've wanted to introduce PCV, but we do not have data that as we speak. It is not a notifiable disease. It's only available in 2005 in Malaysia, licensed. But since 2005, it is available in a private facilities. In that sense, in Malaysia context, usually, in rough estimation, about 70 to 80% of our population will go to the government facilities, health clinics. Only 30% will go through the private facilities. The reason being is because the medical services in Malaysia is subsidized by the government. You have to pay very minimum, and it's very minimum, less than $1 to get to see a doctor and get all the free medication. So that is a bit of introduction. So following this, we wanted to introduce routine, whether or not impact of routine Prevnar 7, which is the 7-valent available in terms of vaccination infant on clinical economic burden, given the fact that we do not have data on that, but we use modeling, and we took 6 hospitals located in Malaysia and to see through the ICD-10 ICD coding, looking for all-cause septicemia, streptococcus pneumonia. So outcomes and cost effectiveness if whether introducing vaccine as a universal infant could potentially lead to direct as well as indirect effect for the society. So basically, if you look at this table you can look through the paper, outcomes and cost effectiveness in pediatric population. If you have no vaccination, 51,000 cases. If got PCV7 vaccination being introduced university, you can get 47. That is, you basically prevent around 4,000 hospitalization, and then eventually this lead to ICER of 35,000 ringgit Malaysia. That is equivalent to 10,000 US dollar, which is cost saving in both direct and indirect. Demonstrate the national pneumococcal is highly worthwhile investment for the population. So this is one data, although we do not have actual data on pneumococcal surveillance, especially in children, but these are the modeling results that help us introduce that. Although it take a little while, 2011, 2016, and as we move forward, now we have seen there's a lot more available pneumococcal vaccine in the market. Started off with PCV7, we have 10, we have 13 and 15, now we have 20. And I know that Pfizer is doing 25 now, 25 valent pneumococcal, which has got a very promising protection, especially against serotype 3. So this is another study, cost-effectiveness analysis of infant universal routine pneumococcal vaccination in Malaysia and Hong Kong was published. Again, looking at the Malaysia's case-based scenario in which we're looking at the invasive pneumococcal disease. If you compare no vaccination and whether you want to introduce now that PCV 10 is available, whether or not no vaccination versus having PCV 10, how much reductions of the cases compared as well to PCV 13 and no vaccination, and PCV 13 and PCV 10. So you look at the life years saved, 129 composite measures that was gained from this study, and it shows that this expanded benefit of PCV 10 over 13 over 10 stimulated cumulative over 10 years outcomes if a universal routine vaccination was introduced. But then again, this modeling would give an extra weightage on the decision-making process. Again, we need to look as well at the financial constraint of the country, but we are grateful enough that Malaysia introduced pneumococcal conjugate vaccine in 2020. We started off with PCV 10 and then PCV 13, and now we have seen is and following that, when you introduce a program, you need to see whether the vaccine has been very we need to have an outcome and monitoring and evaluations of the vaccine of the program itself. In that way, we've seen a marked reduction in the number of IPD cases through a reductions of 2 per 100,000 in 2015 to less than 1. So we're looking at very minimal now, the number of IPD cases through the universal vaccination program. But again, it is getting very complicated in a way that we have seen many more vaccine serotypes available, and with more serotype available, whether or not immunogenicity creep, that immunogenicity creep is a real problem, and are we chasing numbers over that? So again, when we introduce this, the surveillance has to be strengthened in such a way that it is locally tailored to the country specific. So this is just another simulation from the particular study. The graph on A is on the payer's perspective, and B is on the societal perspectives, whether we should use 13 over 10. So what UNI has presented is through the guidance modeling published through WHO. So this is just a repetitions of what UNI has presented. This would be the processes that very much structured in a way that help immunization, especially the NITAG, CPI managers, and the RITAG to look at the modeling processes on how to make a decision, immunization decision-making policy. So again, this is just to reiterate that effectively with collaborations with effectively with modelers is very responsible. It's very important that you need to know the roles and responsibility, and how do you want to internally communicate, and this is what UNI has presented. So this is just another repetition. So with that, I thank you everyone for your kind attention, and over to you, Sheetal.
Thanks so much, Juan, for that informative presentation, and wonderful to see an application of modeling in country to achieve and to demonstrate very good outcomes. So now is a time where, as the audience, we are able to ask questions, and I do encourage you to put any questions through to the Q&A, and I see some have been put through already, as well as into the chat if you would prefer. And thanks, Salim. I think you'll be sharing some of those questions. So This is perhaps a question to the chair, and I wonder if this is best addressed perhaps at the end of the webinar, and let's move to questions that are directly related to the last two presentations. This question was just answered in the chat. So thank you, Yaya, for your question on structural equation modeling and the use of secondary data in Mali. And thanks to Uni for sharing the answer in the chat. Perhaps Uni, for everyone's benefit, would you perhaps shed a little bit of light on the answer that you provided to Yaya's question on structural equation modeling and the use of secondary data?
Yeah, thanks Yaya for your questions. So structural equation models are certainly a type of the quantitative model, but it is classified as a statistical or causal inference models rather than the mechanistic mathematical model that actually simulate the dynamics of the disease transmission itself. And then your second question is about the secondary data. Yes, of course, this could absolutely be used for modeling in Mali. And then you can leverage household surveys, routine immunization and surveillance data, demographic data, or health facility information, any published studies, and even with a caution, the regional and globally generated estimates. That being said, all models are as good as the underlying data. So it would be good to actually also examine the quality of the local data and then identify the gaps for improvement in the future. Thanks.
Thanks, Uni. Salim, are there any further questions? Okay, so we've got a question now. Perhaps this is to Juan and to Uni as well. Could you shed some light on some of the more important policy questions that modeling should be able to help our African countries answer now, especially when clinical trials and so on can take a long time for us to be getting final outcomes. But could modeling be of help in the interim while we prepare for the outcomes of these trials? Uni or Juan, would anyone like to field that? Sure, Uni, and you could go ahead.
Yes, okay, I'll go ahead first. I think the value of the modeling is actually to help you with the scenario planning in the absence of the complete data. So you can actually come up with a few hypothetical scenarios, for example, around what would be the vaccine efficacy or duration of the protection before the trial results become available. But also what would be for example, for economic analysis, what would be the potential price range and the delivery cost would be for different vaccination strategy that you implement, for example, for adolescents and adults versus the other high-risk groups. So this would be a very helpful tool for you to explore different scenarios based on the policy question that should be primarily identified by your decision makers and country stakeholders themselves. I think at this point, what would be also most important, would be important for global level work would be to actually what would be the demand and also the potential vaccination strategies and uptake would look like in case African countries decide to introduce UTB vaccines. So I think there's a lot of close connection between country level operational planning and also the global level planning for the vaccine access and catalytical instrument development. So I just want to also highlight that connection in addition to your local policy questions that is really pertinent to your own populations. Thanks.
Thanks, Uni. And I think we've highlighted some very important points there, that modeling is not just of assistance to NITAGs in terms of planning for the vaccination program, but also to say our African manufacturers, as well as informing continental and global strategy as well. Thanks. So I think with that, we have reached the end of the first component of our webinar today. So I'd like to thank both Uni and Juan for their presentations. And you'll be able to access these presentations in the online recording of the webinar. So with that, I'd like to thank everyone and hand over for the next session to Elizabeth. Thank you, Elizabeth.
Thanks, Prof. Shital. Thanks for that beautiful summary, very, very concise. And thanks to all the panelists that have asked questions. Please keep the questions rolling in. Use the Q&A or even the chat, but the Q&A preferred. So it's my pleasure to introduce to you this afternoon my prof, like I like to call him, but I'll do the official introduction. Prof. Charles Wisongi is a physician, an epidemiologist, and a global health leader with, just a second. Yeah, thank you. With over 20 years of experience in immunization and evidence-informed decision-making, he served and still is serving as an extraordinary professor and, professor of global health at Stellenbosch University. He is a consultant at the African CDC, where he provides strategic support to the development and implementation of the continental immunization strategy. He previously directed the Vaccine Preventable Disease Program at the WHO Regional Office for Africa and has served as a global, continental, and national immunization advisory bodies on various of such advisory bodies, including SAGE, RITAG, and National Advisory Group on Immunization in South Africa. Prof. Wisongi has authored more than 500 scientific publications, and his research focuses on vaccine confidence, immunization systems, and translating evidence into policy and practice in Africa. Today, he will be speaking to us on vaccine confidence in adolescents and young adults in the context of new tuberculosis vaccines. Please lend me your ears as we welcome to the podium Prof. Charles Wisongi. Prof, over to you, sir.
Thank you so much for that generous introduction, Elizabeth. And good morning, colleagues. I would like to thank Nesh too for the invitation to join this webinar series. Today, I will discuss vaccine confidence in adolescents and young adults, with particular attention to the opportunities and challenges surrounding future tuberculosis vaccines. As several TB vaccine candidates move through late-stage clinical trials, understanding how people think and feel about these vaccines will become just as important as demonstrating their efficacy. Slide 2, Salim. Immunization has changed dramatically over the past 5 decades. When the expanded program on immunization began in 1974, vaccines protected children against only 7 diseases. Today, WHO recommends vaccines across the life course, from pregnancy and infancy through adolescence and adulthood and older age. This evolution reflects 2 realities. First, vaccines are protecting against an increasing number of diseases. Second, many important vaccines, including but not limited to human papilloma virus, influenza, COVID-19, respiratory syncytial virus, and future TB vaccines, target adolescents rather than infants. This means that vaccine confidence beyond childhood becomes increasingly important. Slide 3. The TB vaccine pipeline has never been stronger than it is today. Several vaccine candidates are now in advanced clinical trials, and some may become available within the next few years. Importantly, around 90% of tuberculosis disease occurs in adolescents and adults. Therefore, reducing transmission will depend largely on vaccinating these age groups, that is, adolescents and adults. Scientific progress alone, however, will not guarantee impact. Successful introduction will depend on public confidence and willingness to be vaccinated. Slide. This international survey conducted by WHO, UNICEF, and Gavi asked experts what factors will most influence the future of immunization. Trust and misinformation ranked first. This is telling. Even with excellent vaccines, programs cannot succeed if people lack confidence in them. Future immunization programs will therefore need to invest as much in trust as they do in vaccine development. Slide. And talking about misinformation, we conducted a study published in BMJ Global Health in 2020, where we demonstrated that increased exposure to misinformation on social media is associated with declining vaccine confidence and, over time, declining vaccination coverage. Social media has transformed how health information spreads. Unfortunately, accurate information and misinformation now compete equally for attention. However, misinformation is only part of the story. To understand vaccine confidence fully, we need to understand the broader behavioral and social drivers. Slide. The WHO Behavioral and Social Drivers of Vaccination, the BEST framework, provides an excellent way of understanding vaccination behavior. According to this framework, vaccination decisions are influenced by 4 interconnected domains. First, thinking and feeling, which includes confidence in vaccines. Second, social processes, such as family influence, community norms, and recommendations from health workers. The third domain relates to motivation, or the willingness to be vaccinated. And finally, the fourth domain, practical issues, includes access, convenience, and quality of services. Vaccine confidence is therefore only one component of a much broader behavioral system. Slide. The next 3 slides present findings from a national survey conducted in South Africa under the leadership of Heidi Larson from the Vaccine Confidence Project. These findings provide an important glimpse into how people might respond when new TB vaccines become available in South Africa. Slide. Overall, willingness among adults ranged from approximately 56% to 65% across the 10 provinces. That is encouraging. However, perhaps the most important finding is not acceptance itself, it is uncertainty. Around 1/3 of respondents, as you can see on this slide, remain undecided. Experience from many vaccination programs shows that these individuals are often the most responsive to trustworthy communication. Therefore, they represent the greatest opportunity for improving vaccine uptake when TB vaccines become available in South Africa. Slide. Vaccine confidence is somewhat lower when parents consider vaccination of their children. Parents naturally apply a higher threshold when making decisions for their children. Again, as you can see from these results on this slide, uncertainty is important. This suggests that communication for future pediatric TB vaccines will need to address parental concerns early and clearly and transparently, especially around safety and effectiveness. Healthcare workers and schools will be particularly important trusted messengers. Slide. Respondents in this survey in South Africa were also asked whether they believed a future TB vaccine would be safe, would be effective, and would be important. Vaccine confidence, as you see on this slide, was generally high. 74% believed that the vaccine will be safe. 80% believed that it would be important, and 75% believed that a future TB vaccine would be effective. These three dimensions, that is safety, importance, and effectiveness, form the foundation of vaccine confidence. But confidence is dynamic. It can increase or decline depending on communication, depending on media reporting, and it can increase or decline depending on people's experiences. This is why confidence should be monitored continuously before, like we're doing now, and after vaccine introduction. Slide. Among those willing to receive a TB vaccine in South Africa, around 40% said they would take it immediately. Others preferred to wait several months or even longer, with about 16% saying they would wait longer than a year after the TB vaccine becomes available in South Africa. This pattern is common whenever new vaccines are introduced. Many people prefer to observe early experience before making their own decision. Program managers should therefore expect uptake to increase progressively over time, rather than immediately reaching maximum when it is the vaccine is introduced. Slide. There's quite a bit of data on this slide, and I just want to wait to ensure that you absorb that. So among those willing to take a TB vaccine, around 40% said they would take it immediately, like I just said. But participants were also asked about the different vaccine technologies. Interestingly, willingness was broadly similar across mRNA vaccines, protein subunit vaccines, viral vector vaccines, and live attenuated vaccines. What this suggests is that people are less concerned with the technology itself than with whether they trust the process that established the vaccine as safe and effective. Communication should therefore focus on the strength of the evidence and the integrity of the regulatory review, rather than the technical details of the vaccine platforms when the vaccines become available. Slide. And to put this in context, let's look at another vaccine, HPV vaccine. This slide illustrates an important lesson that extends well beyond HPV. We conducted a global Cochrane qualitative evidence synthesis, which included 71 studies from every WHO region, and found that HPV vaccination decisions are shaped by a complex web of interactive influences, not simply by knowledge or misinformation. We identified 8 broad themes, which are shown on this slide. These include people's understanding of the disease and vaccine, perceptions of risk and benefits, previous experiences with vaccination, family decision-making, social networks and media, trust in governments, healthcare workers and institutions, sociocultural beliefs, and practical issues such as access and service delivery. The key message is highly relevant for future TB vaccines. People do not decide about vaccination based on scientific evidence alone. That is the message. Their decisions are shaped by trust. Their decisions are shaped by relationships. Their decisions are shaped by lived experiences. And their decisions are shaped by the wider social context. If we want future TB vaccination programs to succeed, we must engage communities early. Listen to their concerns, build trust, and design services that respond to people's realities, not simply provide more information. Next slide. I will simply mention some earlier work from our group that is relevant to TB vaccines confidence. The work we've previously done suggests that vaccine confidence and hesitancy often arise through 2 broad pathways. One pathway reflects experiences of social exclusion, where distrust grows from marginalization and unequal treatment. The second pathway reflects what we call neoliberal logic, which is individualized health decision-making, where vaccination is viewed primarily as a personal rather than collective choice. These perspectives from our earlier work remind us that vaccine confidence is fundamentally about trust and about social relationships. Next slide. So let me conclude with 3 key messages. The first is that new TB vaccines have enormous potential to transform tuberculosis control. The second is that current evidence from South Africa as presented is encouraging, but substantial uncertainty remains. And my third message is that vaccine confidence cannot be built at the time of vaccine introduction alone. It requires sustained engagement with communities, transparent communication, trusted healthcare workers, responsive health systems, and continuous monitoring of behavioral and social drivers. Ultimately, vaccines save lives, but only when people have confidence in them and choose to be vaccinated. And with that, I would like to thank you very much for your kind attention.
Thank you so much, Prof, for that very beautiful and insightfully delivered presentation. I see we have a question first, so I'll turn it over to Salim. Salim, can we have the first question for Prof? Thank you. So, Prof, Dr. Casey from France is asking, in your research into vaccine hesitancy, did you collect data on the participants' level of health literacy, which is often cited as a factor that mitigates vaccine hesitancy and is therefore a potential area for intervention? Did you or did you know of any who did? Hello?
Charles, you're on mute.
Oh, okay. I wonder what I was saying to myself. So, yeah, this is an important question. As you saw in my concluding slides, vaccine hesitancy, the drivers of vaccine hesitancy are multifactorial. So, what we have concluded, where we came up with the two-pathway theory of how vaccine hesitancy develops, where some people will they are hesitant because they have been socially excluded, they have been marginalized, they have received unequal treatment, and therefore they don't trust the system that provides a vaccination and and every other thing that system provides, and therefore this translates to vaccination, where trust in vaccination is not in isolation; it's part of broader mistrust around it. And then the second one about neoliberal logic. There, you would find in the neoliberal logic, people who think about seeing vaccination as an individual choice and not a collective choice, they are well literate. Some of them well-resourced, high-income people. So what I would say here then is that while health literacy might be a reason in some settings for vaccine hesitancy, and we need to provide accurate information, that is not the only thing that causes vaccine hesitancy. Over.
Thanks so much, Prof. I don't know if we have the time to take maybe one more question. Okay, what tips can you give to modelers that will enable them to better model vaccine confidence among this vulnerable and peculiar population? Because we talk about adolescent, and we know that phase of life is different from every other phase.
Okay. So, in the previous two presentations and the moderation by Professor Sila, which focus on modeling, you would see that one of the things they talk there is about having data from the various contexts, having up-to-date contextual data. And that contextual data include data about vaccine confidence. So modelers should ensure that they have up-to-date information when they are modeling for a particular setting. If they were modeling for South Africa, they need to look for up-to-date information, the most current and most reliable evidence around vaccine confidence in that setting that they can build into their model. And like Saul said, a model is only as important as the assumptions that go into it. So the more current you are, the more likely that it will be a more current and reliable model.
Thank you so much, Prof. Salim, do we have any more questions for Prof?
I would like to run to the WUNEC data presentation.
Right, sir. Thank you so very much. We wish you all the best in your future endeavors. Thank you so much. Back to the organizers. Thank you.
Thank you, Elizabeth. I'm Tony Hawkrich from Niche. Good afternoon, everyone. Bonjour, bon dia. We're running a little bit short of time, so our next guest is Professor Were from Kenya, and he has a very long and impressive CV. And Prof. Fred, if you don't mind, I'm going to give the short version, just in the interest of time. So Professor Were is the Professor of Perinatal and Neonatal Medicine He's the Dean Emeritus at the School of Medicine at the University of Nairobi. He's also the Chief Executive Director of the Kenya Pediatric Research Consortium, Capricorn. He's a past chair of their NITAG, and he plays a number of other very important roles in Kenya. And he's going to talk to us about Kenya's perspective on preparing for TB vaccines. So over to you, Prof. Were.
Thank you, Anthony, and thanks for my delayed joining. This South African time should be the same as Kenya, so that you don't get mixed up. That's for another political conversation. Yes, as the slides are with you, somebody mounting them?
I'm sure we can project them. Salim.
Go ahead. I'll introduce us some remarks as they are being projected. There was a meeting in a related subject which came to Nairobi, and a number of people who are at this meeting are present. Lots of exciting conversations around the very welcome development towards new TB vaccines. And in that meeting, there were two young ladies who had both been my students many years earlier, and one called Margaret Kadure, who spoke about the thinking of the TB program. We have a separate program that looks after TB primarily. And then Dr. Ross Jalango, who spoke about the immunization program itself. And it's good anxiety about when this one's come. So I've actually combined those two conversations and with embellished a bit more language from myself to share this meeting. So shall we move on to the next slide? Yes, I'll try to keep it to three messages. One about the TB program, where they think we are with the disease itself, and the API program, the Kenyan one, the preparedness intended or present, and a few words about what we think we need to do to be absolutely ready and even to speed up the readiness for the country. The next slide. Yes, go to the next one. So the National TB program is housed in the Ministry of Health. The Ministry of Health looks after those dynamics of the country that is divided into 47 subunits called sub-counties. I'll mention that a bit later. But we have presently an estimated incidence of 117. We have 117 cases, which we see annually within, give or take, and giving us 207 per 100,000. The notification rates in 2025 was just under 91,000. The coverage of treatment is 81%. We should like it to be at 100. Case notifications in that year, we had 816. The patients facing costs because of care of TB. 27% of that is pretty large. That is an older survey of 2017. We haven't had another one. We have little reason to think that it's any better now because the economy hasn't improved. The other data is about TB, HIV, co-infection, which we see in a quarter of the cases, and the case fatality of 5%, which is very high. Contributing factors that we have pinned in the Kenyan space is alcohol, diabetes, HIV, of course, smoking, and just people who are undernourished. And that is not confined to children. It includes adults as well. The next slide. And then the program has some good visions there, contributing to what we call Vision 2030, the big document you have had in this country from 2009, even ahead of the SDGs. And we really aim to get zero deaths from disease, especially tuberculosis. And the mission is to provide equity across the cost-effective, access to cost-effective, quality-assured TB, leprosy, and lung health services. And actually by 2030, to end those two diseases, which are pretty related, as we know, microbiological. The next slide. Yes, the mandate of that group is to provide leadership in policy and standards and guideline development, to also mobilize resources locally and otherwise that are focused onto this disease. I know you'll argue that we are pushing ourselves to vertical rather than the usual synchronized or integrated, but one group has to fight for theirs so that you combine. Monitoring and evaluation and research around TB is part of the mandate of this group. And of course, advocacy and enhancing partnership. The next slide. Just a few dreams that we are targeting. Until then, there's that pathway that sort of indicating pathway like by selling us stations of where we should be by then. Where we want to reduce deaths by 90%, incidents by 80%, reduce and proportion of people with leprosy also down by that level. And then basically one important thing at the end there, at the middle there is 0 families facing catastrophic costs due to TB. And all this will not happen simply by lowering the price of TB treatment. It has to include the theme that we're discussing, TB vaccines. The next slide. There is some information here. I think I won't dwell too much onto it. In that meeting, we shared, the team shared the number of issues, the notification rates, and all across the private sector TB notifications, public sector notifications. These are the common indicators that we use. And these slides will be available. You can have a look. We are ranging sometimes as low as 17% in the community referrals, which is not a good thing. And some cases are getting closer to 100. The next slide is giving us some key epidemiological factors, again, which we did blame a number of things. We can now, available data can help us say that the harmful use of alcohol contributes probably to development of about 8.4 thousand, 8.4, yes, thousand cases, attributable to diabetes, 3.8, and all the way down to those that are due to malnutrition being the highest as expected. TB is a bit, HIV is a bit higher. The next slide. So, having looked at the program side, the program has all its wishes of understanding and controlling and knowing the quantification. But then we know that among the things we do, treatment won't be enough. Identification and other preventive measures won't be enough. Then comes the EPI program, which has to be prepared for all incoming vaccines. And this is where we are in that case. This is the one I directly help as chair of the NITAG. Next slide. Yes, the EPI also reported, and I think it's good for us to know, some discomfort that we have a country with 47 subnational units and 1 national unit, a total population of 57 million as of end of last year projections. And we are with the target population that would vary as if you divide them into ages. We have 1.7 annual birth cohort, 7.4 under 5 million, and about 1.8 million pregnant women that were expected in that period of time that leads to live deliveries, actually. The supplies were mentioned. We have some challenges sometimes that we see in the cold chain, which were espoused. We have many facilities that provide vaccination. We have a total of 115,000 facilities in Kenya, of which 9,000 participate in the EPI program. And we'd love that everybody who has a facility is interested in this. And some sort of integration in community and surveillance systems exists. The next slide. This basically, you may not see this as clearly. That's the organogram of the ministry. You have the Ministry of Health, then you have the Directorate of Family Health. Our ministries have a lot of granulation. This Family Health is one of 8 and probably now 9 directorates which focus on something or another different. Then on the side there are advisory bodies where the NITAG exists, and those then flow down through National Vaccine and Immunization Program with the subunits that you're seeing down there. policy direction, the things that they're supposed to do, and departments, sub-departments that help in that. The next slide is, yes, this is the first and still existing NITAG. Christianite is KENITAG. You can see some of those members might be familiar to a few here. Charles has escaped, but the first chair in 2015 and haven't managed to be relieved into retirement. The next slide is, yes, just a few words about how we make our decisions in the KENITAG that we feel, keep moving, that we feel will be useful in speeding up adoption when the vaccine becomes available. We look at what priority it occupies in the country, and Kenya is one of those big contributors to TB disease in the world, so there's no question there. What is known about the disease, we know quite a bit, the impact of that intervention. So that's standard list of things that are in every NITAG's framework. And move again, I think there's something which should be leading us having evidence-based decision-making for new vaccine introduction. We go through all those. We know a lot about what we survived with the BCG, and we also know what it wasn't able to do, and why we must embrace new approaches in addition to it. The next slide is just giving us an idea of the criteria we use. More specifically, in introduction, we need to have some idea about the health impact, mortality where possible, for specific populations or for the population. Then there are other additional epidemiological, epidemic potential, the public health prioritization around the world, the possibility of herd immunity, the usual information we need that is employed by the NITAG. Then feasibility of implementation. And we throw in a few words about financial viability. We are a Gavi eligible country, which is going to be graduated probably 2030, probably a bit later. Gavi keeps shifting the goalposts in our favor sometimes. The next slide is just looking at the vaccines introduced in the country in the last 10 years, and there are plenty really. I think these are known. They're even included in Charles's presentation. Pneumococcal vaccine in 2010, and since then we have had heaps of others until the introduction of typhoid, conjugate typhoid vaccines last year into the program, which is ongoing. We have a bit of teething problems there. Like you heard, that introduction is number one. Sustaining it and allowing it to grow into where you want it to be is another story which we are battling. The next slide is what I said. What we feel is the promise of new TB vaccines, the policy perspectives. We are aware that where we are with the current BCG and its limitations. We acknowledge what good it has done for mankind, and we also now we are better informed than 1974, when it was the only one introduced, as we have gone on since time. And we know that the future is promising. And for that, in Kenya, we feel prepared that when one is available, the introduction guidance is existing. The process has matured from 2014, 2015, when we started making the decisions. So the new vaccines will have not too much difficulty in acceptance, as long as probably the issues of the data that we just mentioned. So the integration is another approach of public health that we are warming up to. How does it join our existing interventions? So we, for instance, we have adopted the life course approach. We have got a new primary healthcare program which is supposed to integrate various things, including vaccines. So despite that martial situation, opportunities exist in Kenya, and preparedness to receive a TB vaccine in the different age group, notwithstanding challenges, including what Sir Charles, I used to call him Sir Charles, when we were together at the SAGE, shared no difference in Kenya, between Kenya and South Africa. I think that might be the last slide, is it not? Next It should be, yes. Yes, that's where we are. Thank you very much. I hope I have not consumed more time, Anthony, than you had given me.
You've done very well. Thank you, Prof. We are pushed for time, but it would be sad if we didn't have time for just one question. My take home from your talk and also the other three is just the complexity of the health systems which we all deal with, and also the variability. So within Kenya, the range, you talked about the social determinants. So the task facing each NITAG is slightly different, and you can't have a sort of one size fits all. But let's just ask Salim, are there any questions for Prof. Were? You could maybe take one, and then I'll have to hand over to Petronella. Here we go. All right. So in your country, what has been done to map out the stakeholders who will be key to the initiative, the introduction of the new vaccine? Which ones will likely be driving it, and which will be providing critical support? And where do you anticipate opposition, and what can be done to mitigate or neutralize it? That's quite a long question, but take a stab at that.
I'll have a quick go at it, and this one would need that we have a full afternoon discussion because I'll always learn more from this exciting audience. We have at present the approach that we do get. Remember, I pass rather quickly. We have the Ministry of Health as we have it. It has a strong communication department. It has what we call the ICC, which participates not only the interagency coordinating committee, where everybody sees, including CSOs and the international NGOs like WHO, UNICEF, and that. So the groupings that can work together is not in short supply in Kenya. And the driving force within the ministry is also there because we have set aside an independent department just for communication and learning what the public is looking for. So the point about that is that with so many people being interested and involved in immunization in general, and TB being another well-known disease, how do we make sure we have the same voice? And I can't deceive you that you already have that one. We've got to create it. There are those who have very little confidence in what BCG did, and it will because people still got TB despite the infection. We popularize its role, not necessarily a complete preventing severity, but the number of stakeholders in Kenya is so large that even bringing that down into a small enough group to have a coherent message will be a challenge. The only plus side for Kenya is that we do have a department set aside for that exact job within the ministry. But that's one story in the Ministry of Health. But in the Nairobi, there are 47 others, subnational, which must then consume what comes from the national office and hopefully use it to run with the entire program. I have not answered you as comprehensive as I would because there is actually a comprehensive answer. It's a recognition that these are serious challenges we must run with. Thank you.
Thanks so much, Prof. I think we're going to have to call it a day there, otherwise I'll be in trouble with my boss. But thank you to you and to all of the speakers for giving so generously of your time. So I'm going to hand over now to Petronella Ngube, who's going to speak briefly about M&E, and then Edina is going to send us on our way. Over to you, Petronella.
Thank you so much, Tony, and thank you to all our speakers. So before we close, we really appreciate if you could take 5 minutes or even less to fill out the poll that is appearing on your screen. Really, the idea of the poll is to receive feedback from all of you to help us evaluate today's webinar, but also it will serve as an important mechanism to ensure that our future webinars continue to meet your needs on TB vaccine and modeling as well. So we particularly interested in understanding how useful this session was, how you plan on applying what you've learned, and any additional modeling topics or support that you'd like us to think about in terms of our future planning for our next webinar. So please take this time to fill fill in the short poll. If you have any questions, let us know. But thank you so much for your valuable feedback and for staying with us throughout. So we look forward to also using your suggestions. So be aware that we are going to use the data that we receive and the feedback that we receive in terms of tailoring our future webinars on this topic. So please take time to fill in the poll that is appearing on your screen. It's only about 4 questions. We've also tried to make sure that we translate it to French and Portuguese so that everyone can be able to fill it in. So if you have any questions, let me know, but I'm hoping that it's very clear and straightforward. I can see we only have 10 people that have completed. Please try to complete as much as you can for those that have not started yet.
Petronella, seeing as we have a minute to go, perhaps as people respond, I could do the wrap up.
Definitely.
Thank you, Petronella. So just in the interest of time and last minute to go, I just thought it's important to thank our speakers who have made the time to share such great insights. It's definitely given us enough to think about. The idea is to incite conversations around how we can start to prepare for new TB vaccines. And what we've heard from Juan and Charles and Fred and Sue, I think all of that is really, really important. And there are some critical key takeaways for us. But aside from the panelists, I think an important thank you to all of you who have joined us from all around the world. It was interesting to see the hellos from different parts of the region, as well as other continents and other countries. About 160, 170 joining us throughout the course of the hour and a half. So thank you so much for your time. There have been some questions about resources, just to let you know that this current webinar, the slides, the recordings, as well as those from our previous webinars are available on the NITAG Support Hub website. So please do check those out. And lastly, our next webinar will be taking place in September, the 23rd, and we will communicate about the topic on our website as well as on our LinkedIn page. So thank you so much for your attention. Thank you for responding to our poll. Please continue to respond to that. And please do keep engaged with us. And I think with that, we will bring this to a close and hopefully we'll be able to join in together later in the year. Thank you very much, everyone.
Thanks, everyone. Bye, everybody.